Hi, and welcome to this talk in which we'll go over some thoughts on how to write a note. My name is John Wurzel. I'm one of the faculty psychiatrists at Sacred Heart Medical Center with the Psychiatry Residency Spokane, and I appreciate you joining me for this. So the goal of this talk is to think about how do we develop a way to write a note that makes the note as useful and as efficient as possible. And in the service of doing that, I want to take a step back and think about a note as a form of communication. And then think about what is it that makes communication successful, right? So I want you to pause this and write down what defines successful communication. To me, probably the most important measure of whether communication is successful or not is whether it conveyed the information that needed to be conveyed. And then we would need to ask, well, who determines what information needed to be conveyed? And who determines what information is conveyed, right? So again, stop and think about who determines what information is conveyed. If we think about communication dichotomously in a sender-receiver dynamic, where the sender is the person talking or writing, and the receiver is the person reading or listening, then in that dynamic, as the sender of information, we determine what information might be conveyed, what is available for conveyance. But only the recipient of the information actually determines what is conveyed, because they determine whether they understood the information that you were trying to communicate to them. Because of that, I would argue that when you communicate with someone, you need to consider that communication from the perspective of the recipient, because they'll ultimately determine whether your communication was successful. So, as we apply this to notes, and we'll do this in kind of a rational way, but I want to start with a couple examples, and then we'll look at what makes them useful and not. Before that, though, first we need to figure out who the recipients are. So who reads your H&Ps or your consult notes or your progress notes? And I would argue that that includes other physicians on your team, your residents, your attendings, people who are evaluating you, but also consultants and consultees, the nurses, physical, occupational, recreational therapy, social work, other support staff. There are lots of people who read your notes. And we have to bear that in mind when we're thinking about, well, what do these people need to know? So now let's look at a couple examples and think about what makes notes useful and not useful. Here's our first example. We've got a 64-year-old woman, history of COPD, coronary artery disease, hypercholesterolemia, type 2 diabetes, status post left hip replacement, depression, insomnia, and anxiety, who presents for care of depressive symptoms. Patient is depressed and anxious, continue Seroquel, continue Abilify, disposition undetermined. Think about assuming that this is a patient whose care you're assuming. How useful would you find this? And now let's compare it to this note. Patient is a 64-year-old woman with complicated medical history, depression, insomnia, and anxiety, who presents for care of depressive symptoms. Diagnostically, patient meets criteria for a major depressive episode with symptoms including low mood, anhedonia, insomnia, etc. The underlying etiology of her depression is likely bipolar II disorder. She's clearly described previous episodes of hypomania and major depression. She also meets criteria for a generalized anxiety disorder with worries about various aspects of her life that have produced multiple physical manifestations. Therapeutically, given a bipolar II diagnosis, antipsychotic treatment is appropriate. Patient has not responded to an adequate trial of Abilify, therefore will cross-titrate to Seroquel, which is an evidence-based treatment for bipolar depression. Given that Seroquel is also an evidence-based monotherapy for generalized anxiety disorder, we'll hold off on beginning an antidepressant at this time per patient request, to see if Seroquel monotherapy will be effective. Her disposition is unclear. With resolution of her depression, she may functionally improve to the point of being able to return home. So, you're the recipient of the notes in these two examples. Which note is more helpful? and I would argue fairly clearly, that the second note is more helpful. But then we have to ask why, right? And so I want you to ask yourself, what questions do you, as the user or the recipient of the note, need to have answered in order for this note to be useful? They're the same case. The clinical scenario is the same, but the notes are different. What makes the second note more useful to you? What information do you need that note to answer for it to be useful? So look again at the first example note. Pause the video and write down what you think is useful and not useful about this, and what you have learned after reading this note. So here's what I know after reading through example number 1. I know she's got a whole bunch of medical conditions, but I'm not really sure how they play into her depression, for which I'm trying to treat her. I know that the author believes that the patient has depression and anxiety because it says patient depressed and anxious. I don't know whether the patient actually does have depression and anxiety, and I also don't know why the patient is having depression. What is the underlying etiology of the depression? I know that the author intends to continue Seroquel and to continue Abilify because it says continue Seroquel, continue Abilify. And that makes me think about how treatment with multiple antipsychotics is not evidence-based in almost any circumstance, and how, boy, we said that this patient has depression and anxiety, and I don't really think about antipsychotics as evidence-based treatment for depression or anxiety in the absence of an antidepressant in most circumstances. And finally, I know that the patient's disposition is undetermined, but I have no idea what will ultimately determine it. So now, let's do the same thing with example number 2. I want you to pause the video and write down what you know and what makes this note useful and not useful after reading through it. Here's what I know after I read through the second note. First, I know that the patient has multiple, probably non-contributory medical issues. I know that they're probably non-contributory because the author in no way spelled them out nor mentioned them contributing. I know that the author thinks the diagnoses include a major depressive episode and a generalized anxiety disorder. And I know that the diagnosis of a major depressive episode is justified because the author referenced low mood, anhedonia, insomnia, etc. And so the patient meets DSM diagnostic criteria for a major depressive episode. I also know that the author diagnosed generalized anxiety disorder for a good reason because they're noting worries about various aspects of the patient's life that have had produced multiple physical manifestations, and those are at least some of the criteria for a generalized anxiety disorder in the DSM. I know that the major depressive episode is likely attributable to bipolar II disorder because the author cites evidence that supports a diagnosis of bipolar II disorder, clearly described previous episodes of hypomania and major depression. I know that the author intends to continue Abilify and Seroquel, and I know that the author is using Abilify and Seroquel as evidence-based treatment options to treat bipolar II disorder, as well as that the use of multiple antipsychotics is appropriate because this is a temporary situation in which they're cross-titrating from one to another. I also know that cross-titration is appropriate because the therapeutic failure of Abilify. I know that antidepressants have been considered, but may not be necessary. I know that the author knows that Seroquel monotherapy is So pause now and try to think about, as the recipient or the user of a note, what information do you need to get in order for that note to be useful? We need to know, what illness is the patient suffering? What are their diagnoses, right? And what evidence supports the diagnoses? Should I believe your assessment? And how much stock do you put in your assessment? What's the evidence that supports it and that argues against it? What do you believe the underlying etiology of the illness is, if relevant, right? And then what should we treat the illness with? And what evidence is there that that treatment will work? This is essentially a summary of the job of a physician, right? We go through all this training in order to be good at figuring out what illness does this person have and why do I think they have that and what should we do about it, right? So we really want to make sure that we're communicating this fundamental aspect of our job in our notes. If we simplify it, we could simply say that a note needs to explain what was or is wrong with the patient and why do we think that that's the case, and what should we do or did we do about it, and why do we think or did we do it. Now, outside of all the receivers or the users of your note, I would say there's one other person who has a vested interest in your note, and that is you. And if you ask any practicing physician, the general goal in writing a note is to be done writing the note, right? Now, there's a number of ways to be done writing the note. You can cut content. It improves your efficiency dramatically, but it decreases the usefulness of your note dramatically, and sometimes you end up, not that uncommonly, unfortunately, you end up in a situation where the note's just not useful to any of the potential users of it, and so it actually is rendered writing the note kind of pointless. You're going to the time and energy to write this note, less time and energy because it's so short, but no one can use the note, and so it still was kind of a waste of time and energy. So I would argue that rather than cut content, improving the organization of the note will increase efficiency and improve utility. Organizing the note the same way every time you write a note allows you to spend time focusing on the content rather than the structure of the note. And we'll go over a structure that can be easily deployed across multiple services and will allow you to communicate the necessary information in an efficient way. That structure is going to be fill in the blank in nature because that's much more efficient than creative writing. So often we end up in a situation where we have a complicated note to write and it takes a really long time to do it because we're figuring out how to write the note instead of just figuring out what to say in the note, and that's not necessary. So let's look at a history and physical exam. So this is the basic structure of the note on the right. You've got your IDCC, your one-liner, you've got your history of present illness and your various other histories, your exam findings, your labs, your imaging, and then you've got your assessment and your plan. And this is how I would write this note. So I divide a note up into essentially 4 sections. The first is data. The data is your history of present illness and all the other histories, your exam findings, your labs, your imaging. Write that section first, right? It's usually organized for you by the general note template, and your job in the data sections is to be complete. So any data that you're going to cite later on, as we'll discuss, you want to appear in the data section. The second part of the note that you're going to write is the assessment, and that's your argument. And that's except for the one-liner, which we'll come back to. So we'll talk about the organization of the assessment, but essentially your assessment is a summary and a synthesis of the data. You are making an argument about what you believe is going on with the patient and what you believe would be the next steps in their treatment. And that's an argument. That's why I think of it as the argument section of the note. So the first thing you're going to do is you're going to write the data section. The second thing you're going to do is you're going to write the argument, in which you're going to cite the data that supports your argument. The third thing I write is a plan, and that's usually just a bullet point based, problem based distillation of the approach to treatment. The last thing I'm going to write is the one-liner. Even though it's way up there at the top of the note, I'm going to write the one-liner after I write the assessment. And the reason for that is that the one-liner, as we will see, is a summary of the assessment. It's a concise synthesis of the relevant information for your argument. And so, despite the organization of the note template, this is the order that I write things in. And I write them in that way because it's logical. You're going to describe the data, you're then going to cite the data in your argument, and you're then going to summarize your argument in your one-liner. So looking more closely at the data sections, like I said, I recommend you write it first. I recommend you use the basic note template for the organization. It's already got broken down into an HPI and the various histories and your exams and your studies, etc. It's already organized for you. You need to be thorough here. Thorough doesn't mean exhaustive. You just need to ensure that every pertinent positive and negative piece of data is represented. Because what you don't want to be doing is presenting new data in the assessment or the plan. So the assessment is where you're going to cite the data that you've already recorded in these data sections. That's really about all I have to say in the data sections. Use the template organization, be thorough, and that's it. Don't get fancy. The assessment. So for me, the assessment is the heart of the note. This is the job of the physician. Your assessment is all about your argument, about what's wrong with this patient and what should we do about it. That's why you're in all this training, in order to learn to be good at making those decisions. You're going to start with a one-liner, and we're going to talk about that in a bit for the reasons I've already discussed. But in general, the assessment is where you're going to answer the question, what's wrong with the patient? Why do you think that's the case? And what do you want to do about it? And why is that the appropriate intervention? And I encourage you to organize your answers to these questions the same way every time, and that will maximize your efficiency. Again, I want you to think fill in the blank. An organized assessment is an efficient assessment. It is also an accessible assessment and makes it more user-friendly. So, this is how I think about it. The first line of my assessment is going to be the one-liner, but after that I'm going to try to answer the questions, what's wrong with the patient and why? And so I say, diagnostically, Mr. and Mrs. blank meets criteria for blank, with symptoms including blank, blank, and blank. So right there, in literally the first sentence, I have said, this is what I believe is wrong with the patient, and this is why I think that's an appropriate diagnosis. The underlying etiology of their blank is likely blank. It is also possible that their symptoms are attributable to blank, which is supported by blank, less likely because of blank. Again, this is what I think might be going on. This is why it might be going on, why it might not be going on. They also could be suffering from this, but it's less likely because of this. Mr. and Mrs. blank also meets criteria for blank with symptoms including blank, 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 and I'm going to repeat this until I've walked through all of the relevant diagnostic considerations. The next paragraph, I'm going to answer the questions, what should we do about it, and why? So I'll say therapeutically, because the patient is likely suffering from blank, which we've already made the argument supporting, most evidence-based treatments would be blank. Right? Alternative possibilities to consider include blank or blank. After discussion of risks and benefits, the patient elected to begin blank. So again, I've already made my argument. This is what I think we should do about it. I've said this is why I think we should do about it. This is what the patient decided to do about it. In order to further clarify diagnoses, it would be helpful to do one of these various things. And then moving on to the next diagnoses, in order to address blank, we will begin blank because studies have shown blank, etc., etc., etc. So again, I'm going to walk through the various diagnoses that I'm thinking about treating. I'm going to explain my proposed treatment, my rationale for doing it. Overall then, it might look like this. You've got your one-liner at the top, your diagnostic paragraph. I usually throw in a brief psychological paragraph after the diagnostic paragraph because it really can help us understand what exactly is going on with the patient. And I encourage you to talk more about this psychological paragraph with your attending and your residents and try to get a better sense of what might or might not go there. And then we're going to finish up with our therapeutic paragraph. I made this into a fill-in-the-blank partly because you're welcome to steal it or borrow it and modify it, right? But what I want you to see here is that it really is a fill-in-the-blank exercise. And if you fill in these blanks, you'll have communicated an enormous amount of useful information, but by making it fill in the blank with a consistent structure, it's not very long to fill in this form, these paragraphs. It should be fairly efficient. So in terms of the plan, I recommend that you keep it simple. And there's an example plan over on the right here. If somebody wants to understand the rationale behind your plan, there's a home for that, and that's the assessment. They can scroll up 2 inches, read through your assessment, and then understand why. The plan is really just what, and it should be as accessible as possible. I think of the people using this as, the nurses who are trying to confirm, am I giving the right dose of this medication? Yes. Or, just the concrete recs that a consultant or a consultee might be trying to look at and understand exactly what the plan itself is. So I organize it by problem, and we've already identified and justified the problems, so we don't need to explain them further here. And then I'm going to list the treatments, which again, we've already identified the treatments and made our arguments for why they're reasonable treatments. And so you really shouldn't need to explain anything. I would say the plan is where I put in dosing and schedules for my medications. Those don't need to go in the assessment. The assessment is my argument about, we should use Zoloft to treat this patient's depression. Assuming that I'm using Zoloft in a relatively standard way, for someone who wants the details of exactly, what the dose is, what the titration is, that goes in the plan, because if I throw it in the argument, I'm just making that unnecessarily long. Now, if for some reason I've decided this person needs to take Zoloft broken up into a 4 times a day schedule, that absolutely merits discussion in the plan because it's weird, and therefore there should be some thought behind it. So finally, let's look at the one-liner. So the one-liner is the summary of your assessment. Who is the target audience for your one-liner? So pause and write down who the target audience of your one-liner is. The target audience is your attending, if you're staffing the patient, a consultant or a consultee, someone who you're handing care off to. Essentially, it's someone who needs rapid orientation to the patient, right? And so what is the goal of a one-liner? When you hear a one-liner, what are you trying to extract from it? So what you need is pertinent information that will help you contextualize the rest of the information that you're about to get, right? If I'm the attending and I'm hearing a one-liner, I'm trying to get a quick sketch so that I know what to look for in the rest of the information you're about to tell me. That's why it comes first, and it's also why it comes at the beginning of your assessment. It helps orient the listener. And because of that, it's all about managing the signal-to-noise ratio. So I'm going to give a bunch of examples to one-liners, and I'm going to ask you to pause and write down what each of them think. So first, Mr. Smith is a 26-year-old man with a history of major depressive disorder who presents with a major depressive episode in the context of medication non-adherence. This is the one-liner that you get. So pause and write down, what do you expect to hear next in the assessment? So you're probably going to hear, diagnostically, the patient meets criteria for depression, with these symptoms, etiologically, that is likely secondary to their underlying major depressive disorder, and that therapeutically, because they are off their meds, they should probably restart their meds, right? So given this one-liner, the assessment that you're expecting to hear is that they have depression secondary to their underlying MDD, and they should restart their medications as treatment. Now, if we change it a little bit, and we say, Mr. Smith is a 26-year-old man with a history of major depressive disorder and alcohol use disorder, who presents with a major depressive episode in the context of medication non-adherence and a recent relapse onto alcohol. Pause it again, write down what you expect to hear in the rest of the argument. So you're probably expecting to hear that the patient's depression may be secondary to their major depression, or maybe alcohol-induced, or maybe both, and that therapeutically they should probably restart their medication, and they should probably consider sobriety interventions, medications, therapy, CD treatment, etc. What if we tweak it some more? So now we've got Mr. Smith, a 26-year-old man with a history of major depressive disorder and hypothyroidism, who presents with a major depressive episode in the context of medication non-adherence. And what do you expect to hear next? Now you hear Mr. Smith is a 26-year-old man with a history of major depressive disorder and a recent open reduction internal fixation of a left humeral fracture, who presents for a major depressive episode in the context of medication non-adherence. So now what do you expect to hear? So you probably expect to hear something about their depression being related to their underlying MDD, but I'm sitting there listening for, what does the ORIF have to do with it? Why did you tell me they just had this surgery? You're, if you're like me, going to spend the whole assessment wondering, what does the open reduction internal fixation have to do with their depression? Because I'm going to assume that you had a reason to tell me about it. And maybe you did. Maybe you're about to tell me that because of their mobility limitations, they've had to cut back on their exercise, which is a major coping skill that they employ, and therefore it is actually quite relevant, and we need to think therapeutically about how do we find other coping skills for the patient, in which case this is an entirely appropriate one-liner. But if it's just part of the medical history, and you threw it in there just because it's part of the medical history, it doesn't actually have anything to do with their depression, you've confused the person who's hearing the one-liner. Most commonly, we hear something like this. Mr. Smith is a 72-year-old man with a history of coronary artery disease, chronic obstructive pulmonary disease, obstructive sleep apnea, obesity, osteoarthritis, previous hiatal hernia repair, hypertension, type 2 diabetes, depression, and anxiety, who presents for care of depression in the context of medication non-adherence. So what do you expect to hear next in the argument? Again, probably something about their depression being related to their underlying depression, but you know that all these medical conditions can't be individually relevant, so you just don't know what to anticipate. Is one of them relevant, or two? Maybe. If I hear this, I'm likely to dismiss it as being pretty useless, because someone has just not managed their signal-to-noise ratio, and so you haven't actually prepared me to more critically think about what's going on. You've flooded me with information. But you may wonder, well, all this stuff is relevant for his care, it just may not be in my argument about his depression. Absolutely, it is relevant for his care, and there's a home for that in the relevant sections of the note, right? It may be in his past medical history, and some part of his plan you may need to say, hey, we should continue his home medications for his hypertension and his diabetes, etc. But unless the issue merits discussion in your assessment, it does not merit discussion in your one-liner. So how do we learn to write a one-liner? The first thing I would say is write the assessment first, because if you're trying to summarize an argument, it's really hard to summarize without knowing what it is. Then, decide what is and isn't pertinent, right? Both the historic data and the current data. What is and isn't pertinent to my argument, and then you're going to write a one-liner in the standard format. Blank is a blank-year-old man or woman with a history of blank, blank, and blank, who presents with blank in the context of blank. The point is, again, pertinent, positive, and negatives. I want to pause for a moment and talk about other considerations, like racial considerations. So I don't include race in my one-liner, race or ethnicity in my one-liners, because the evidence in medicine, and certainly the evidence in psychiatry, suggests that there are very few circumstances in which race is actually relevant to the care of the patient. Now, there are a number of circumstances in which race inappropriately affects the care of the patient. So, for example, African Americans are much more likely to be diagnosed with schizophrenia, whereas Caucasian Americans are much more likely to be diagnosed with bipolar disorder, despite the fact that the two conditions occur at the same rates in both ethnic populations. Or African Americans are more likely to be treated with typical first-generation antipsychotics, whereas Caucasians are more likely to be treated with second-generation atypical antipsychotics, and African Americans are less likely to be tried on clozapine for the treatment of their conditions. But again, none of that has a clinically appropriate grounding. Unfortunately, it's just evidence of implicit bias. There are a very few circumstances in medicine in general and in psychiatry specifically in which race is clinically relevant to my decision making. And so I tend to avoid mentioning race because I'm concerned that it may incite someone's implicit bias more than it will help inform treatment. That said, there are a few circumstances. So for example, if I'm treating a patient with carbamazepine and they are of Asian descent, East Asian descent, then actually genetic testing for a certain major histocompatibility complex is part of the standard of care due to a 100-fold increased risk of Stevens-Johnson syndrome. And so in that case, I would include race in my one-liner, or ethnicity in my one-liner in assessment, because it is relevant. If I am treating, an African-American patient because of post-traumatic stress disorder associated with, hate crimes, then it suddenly becomes relevant again. And so I might include it in that circumstance. So my default is not to include race and ethnicity because I feel like the potential for it doing more harm than good is real. And you do want to be thoughtful about, are there some clinical circumstances in which it's relevant and therefore should be included. Let's turn our attention to the discharge summary. So I would argue that your HPI, your progress note, your consult note, all break down about the same. They may be organized differently, but the structure is still, there's a data section, there's a assessment that is your argument, you've got your plan, and you've got your one-liner, and however they're physically organized in the note, you want to think about them and write them the same. But discharge summaries are somewhat different. So this is what your average discharge summary looks like over on the right, and this is how I'm going to write that. So I'm going to start with the historic data. And usually this is truly historic data, copied and pasted and cited from the appropriate notes, often the H&P, but maybe there's some progress note that had a more thorough social history, and then I would want to copy that history from that progress note. It is important that you copy, paste, and cite. You must cite from someone else's note if you are borrowing text from their note. The next part is the hospital course. So the hospital course is going to be the second thing that you write, and we'll talk about organizing this section in a minute. This should be a summary and a synthesis of what happened during the hospital. There's sort of an other specific information that may or may not be relevant to any given patient, but would include complicated diagnostic reasoning, safety assessments, or other specific issues. And then finally, there's the recommendations, which we'll write last. And as we'll talk about, they should be targeted to physicians and appropriate for a physician level of competence. So in more detail, looking at the historic data, again, organize it by the note template, copy, paste, and cite. Look for the H&P or progress notes, social work notes, wherever you're going to get the best information. Now for the hospital course, I again want to apply the idea of viewing this from the perspective of the recipient or the user of the note. So who reads a discharge summary? Outpatient providers, future emergency department and future admitting providers, and maybe the patients and the family. So when we're designing our hospital course, we need to think about, if these are the folks reading it, what information do they need? What questions do each of these groups need to have answered? So we'll start with the patient and the family. So the patient and the family want to know, what's wrong with the patient, what was treated during this hospitalization, what was the treatment, did it work? And because they're likely not medical professionals, this all needs to be communicated professionally, of course, in complete sentences and without abbreviations. This doesn't mean that you need to explain every diagnosis or treatment, right? Your hospital course is not a medical textbook. It just needs to be accessible enough for them to look it up if they choose to, or to know what to discuss with their doctors when they go in for that follow-up visit. Think about if you are an outpatient provider and reading a discharge summary. What questions are you asking? Pause and write down the questions you would be asking. So you're asking, what illnesses were diagnosed and treated during this hospitalization? How were they treated? Did it work? Did it cause side effects? If it didn't work or caused intolerable side effects, what was tried next? Did it work? Did it cause side effects? If it didn't work, etc., etc., etc. Essentially trying to figure out what was wrong with the patient, what was done about it, how well did that work. If you're an admitting provider or an ED doc, what question do you need answered, or questions do you need answered when you're reading a discharge summary? So really you're asking one major question, which is what I'm seeing now the same thing that they saw during the last hospitalization? Because if it isn't, then reading through the rest of this probably isn't all that relevant. But if it is, then they want to know the same thing everyone else does. What was the patient diagnosed with or treated for? Did it work? Were there side effects? Then what was tried, etc. So in order to help our ED providers and our admitting docs, we need to paint a clear picture of the patient's presentation so that they can compare the two. Looking again at the last involved party, you, we want to think about efficiency, and the same ideas apply. Organization allows you to think about content instead of structure, and almost universally when writing hospital courses, what slows people down is overthinking the structure. So I encourage people to organize the note by section, so readers can find the section that they're interested in, so that outpatient psychiatrist can scroll down to the psychiatric section, the outpatient primary care doc can scroll down to the medical section, the admitting ED doc can scroll down to whatever section seems most appropriate, etc. And then in each section you'll organize your problems into paragraphs, which will allow you to tell each problem's narrative cleanly without having organizational issues. And then within those paragraphs, we're going to organize them the same way every time. Again, think fill in the blank. And so we'll go through examples to make what I'm saying make more sense. So here is what one such paragraph might look like. I'm going to identify the problem. Assuming it's a psychiatric problem, we'll say maybe it's psychosis or depression or anxiety. I'm going to put a colon, and then I'm going to say at the time of admission, the patient blank, and I'm going to fill that blank in with a clear description of what the patient looked like at the time of presentation to help that ED doc or admitting provider compare the patient now and during the future time when they're seeing them. Then I'm going to say, in order to answer everyone's question about, what was the patient treated for? Patient was diagnosed with blank. For example, let's say hospital course, I'm going to say psychiatric, depression. Mr. Smith presented with severe depression, reporting he was unable to leave his home, that he hadn't enjoyed anything in weeks, and that he was unable to make himself eat. He was diagnosed with depression, symptoms including insomnia, suicidal ideation, and an inability to eat. He was restarted on his home sertraline and titrated up to 150 milligrams. At this point, he continued to report significant insomnia and anorexia, though his suicidal ideation had resolved. He titrated to 200 milligrams, but developed significant flushing and sweating. Because of this side effect and the fact that sertraline was only partially effective, patient transitioned to escitalopram 20 milligrams and mirtazapine 30 milligrams. At that point, he reported dramatically improved sleep and appetite and continued to deny suicidal ideation. At time of discharge, patient reported good sleep and appetite, denied suicidal ideation, and was looking forward to returning home. He discharged on escitalopram 20 milligrams and mirtazapine 30 milligrams. So if we look at it, we can see exactly the pattern that we described in the previous slide. So we have the identification of the problem we're going to discuss, depression. Then we're painting a picture in the first sentence so that hopefully admitting providers or ED docs can compare what they see to what we're describing and determine whether the rest of it's relevant. And then we are walking through the pattern of what did he look like? What did we do about it? How well did it work? What did he look like? What did we do about it? How well did it work? Until we run out of that pattern. And then we're going to finish up by saying at the time of discharge, this is how his symptoms were doing, and this is what he left the hospital on. Now, nesting that in the big picture, this is what the hospital course might look like. So I would say psychiatric. I'm going to list problem 1. That might be depression, like it was for Mr. Smith in our example. I'm going to walk through the descriptors, just like we described in the previous 2 slides ago. And then I'm going to do the same thing for problem 2, with the same exact paragraph structure, but addressing a new problem, and problem 3 and problem 4, until I've run out of psychiatric problems. If necessary, I'll do a risk assessment, which we'll talk about. It will be necessary for patients with suicidal or homicidal ideation. If necessary, I'll write a diagnostic clarification. Generally not necessary. It's important if there are significant changes made to diagnoses or a lot of time spent clarifying diagnoses. And then I'm going to transition to my medical thing. I'm going to say problem 1. Same paragraph structure as described for the psychiatric problems, if it's a significant enough problem to warrant it. And then problem 2, etc., etc., etc. Have a social section in which I generally say something like group and milieu therapy were provided to the patient during their hospitalization, if they're in the psychiatric unit. And then I'll mention any significant social work interventions or family meetings that occurred, just briefly. And then I'll have a paragraph on their legal status, which will just say whether they were voluntary or involuntary at the time of admission and discharge, and any date at which that status changed. So looking now at those other paragraphs that may or may not be appropriate, we've got our suicide and our homicide risk assessments, which should be done in any patient who presented with meaningful suicidal or homicidal ideation, regardless of whether it resolved before discharge, particularly if it hadn't resolved before discharge. But even if it had, you still need to do that risk assessment. In the diagnostic clarification paragraph, I usually do in any case where there's a lot of conflicting evidence about the diagnosis. And I do it in a separate paragraph because it keeps my hospital course clean. So I don't have to try to figure out how to tell the story of what happened with the story of my thinking about their diagnosis. Again, it is figuring out structure that tends to slow down discharge summaries more than filling in content. Looking at the risk assessments, so this is an example risk assessment paragraph. This is the structure that I use. Again, I fill in the blank, lets me focus on the content rather than having to think about the structure. So for a psychiatric patient, essentially their risk of suicide is all elevated as compared to the general population. And I encourage you to talk more with your residents and your attendings and with Dr. Cliff Green, who does a really nice talk on risk assessment about these issues, because this particular talk isn't the setting to have an involved discussion of risk assessment, but it certainly merits more conversation than we're about to have. So that I discuss their risk of suicide as compared to the general population, which is generally elevated for psychiatric patients, and then I'm going to discuss why it's elevated and list out static risk factors, often demographic risk factors or historic risk factors. I'm then going to note that their acute risk of suicide is or is not elevated compared to their own baseline risk due to dynamic risk factors, if they exist. I'll list out protective factors that mitigate the risk, and then I'm going to say what interventions I'm proposing. Right? So in order to mitigate this risk further, we will do these things. And then I'll finally say, due to the risk of suicide, and in order to make these interventions, an appropriate level of care is blank. Right? So again, I encourage you to talk more with the residents and the attendings who are helping you in order to better understand this, but this is an example risk assessment. Finally, in the discharge summary, the last thing I encourage you to do is the recommendations, which should be meaningful and potentially helpful. So recommending that someone should continue sertraline for depression to another physician is probably not very helpful because they probably already know it, right? But a recommendation like consider duloxetine as a next option due to the fact that the patient's family members have responded well to SNRIs, but the patient's hypertension may be exacerbated by venlafaxine, that is much more potentially helpful. You're giving that outpatient provider quite a lot of information that they're like, oh, okay, this is good thinking. So we just want to make sure that our recommendations are relevant to whoever's looking at them. And I usually make a recommendation related to the possibility of rehospitalization. So for most patients who benefited from hospitalization, I'll have a sentence like, patient benefited from hospitalization, were they to re-present in similar circumstances, we would recommend consideration of hospitalization again. And for a very few patients who really clearly didn't benefit from hospitalization, psychiatrically speaking, I might say something like the patient did not significantly benefit from hospitalization, were they to re-present in similar circumstances, would recommend therapeutic goals and strategies of hospitalization be clarified prior to admission, which is my way of saying, I don't know how I would help them if I re-hospitalized them, so I would appreciate you clarifying what the goals of treatment and what strategies we might use to accomplish that would be before we re-hospitalize this patient. So, before we go through the summary, I want to address one issue, which is the question of, does this make notes too long? So generally when I review this talk with students, the response is, I can absolutely understand why answering those questions makes notes useful, but what about the risk of it being too long, didn't read, right? And so I think the answer to that is good organization allows you to be concise. Now, there are circumstances where being concise is not clinically appropriate, and in those circumstances, if someone doesn't want to read it because it's too long, I genuinely feel like that's on them. But in most circumstances, being concise allows people to get the information they need quickly, and so they don't have a disinclination to read the note. Also, for example, in your hospital course, being organized allows them to identify and access the part of the information that they want quickly so that they don't necessarily need to read through a bunch of stuff that they're less interested in. I will tell you that if you write notes like this on psychiatry, you'll be in good shape. If you write your notes like this on medicine or OB or a number of other services, the feedback you'll likely get is, that was great, but it was kind of long. That's fine, right? It's okay to be great but slightly long. If the feedback that you're getting is, that was long and it was redundant, then I encourage you to look at whether you're restating data in your assessment rather than synthesizing and summarizing data in your assessment. Now, it's also worth knowing that you really are not writing notes about the service that you're on. So if you're on a surgical service where you're thinking about whether to do, an appendectomy on somebody who has a whole bunch of other issues, and the question that the surgical service is trying to answer is, do we do this appendectomy? They may actually merit a relatively short note because you are trying to answer a specific question. So just because the patient has a whole bunch of stuff going on, again, doesn't mean that it's actually pertinent to the clinical question at hand. And so often I argue that, yeah, surgical notes are very brief, but surgical notes often only have to answer one or two really clear, very important questions, and so it's appropriate for them to be brief. Sometimes they're too brief and they're not that useful, and that's true of, as I'm sure you will either find out or have found out, many notes across many services, absolutely including psychiatry. So in summary, to make communication, verbal communication, written communication, smoke signal communication, any kind of communication, as useful as possible, I encourage you to consider what the perspective of the receiving party is. Ask yourself, if I was reading or hearing this, what would make it useful to me? In order to make communication as efficient as possible, I encourage you to focus on organization rather than on brevity. So don't sacrifice the utility of your note on the altar of the efficiency, right? Organize your communication the same way every time, and then you won't have to waste time reinventing the structure. Fill in the blanks, again, much more efficient than creative writing. And finally, regardless of what the note's physical templates looks like, I encourage you to write your note in a logical order. Record the data, synthesize and summarize the data into an argument, and then summarize your argument into your one-liner. I hope you guys have found this helpful. I appreciate you spending the time, and I wish you a good day.